Welcome everyone to the Beat Goes On Underwriting Atrial Fibrillation webinar. Thank you all so much for joining us. Before we begin, I wanted to take a moment to let you know that we are recording this session and the recording will be available in Academy within 2 business days. As you have questions, you may post them in the Zoom Q&A and we will answer questions at the end of the call. We will try our best to answer all of your questions at the end of the presentation, but if for whatever reason we are unable to get to your question today, please email learning@nfp.com. At this time, I will hand over the call to Cindy Davis, Assistant Vice President and Senior Underwriting Consultant at NFP. Cindy, the floor is yours.
Thank you so much, Amber. Well, thank you all for joining us this afternoon. I know your schedules are very busy and really appreciate you taking the time to tune in for this. We also have on the call today our Consulting Medical Director, Dr. Charlotte Lee. Dr. Charlotte Lee has been practicing for cardiology for over 44 years. So I feel very grateful and appreciative to have an expert on the call to discuss this topic. So what is atrial fibrillation and why are we having this call today? So atrial fibrillation is the most common heart rhythm disorder. I hear it called an irregular arrhythmia, which all arrhythmias are abnormal, but that's sort of what makes this one stand out from itself. And what's so important to it and why we're choosing to talk about it today is it increases both the risk of heart disease and stroke, leading causes of death in the United States. I found some statistics that actually showed that in 2019, the CDC mentioned it was on over 183,000 death certificates as a contributing cause. And also in 2019, and I'm using 2019 as pre-COVID type numbers, it was noted as the primary diagnosis for over 454,000 hospitalizations. So it's definitely affecting a lot of people. It's estimated that 5 million adults in the United States currently have this condition and is expected to increase. I saw several places where it's being estimated to be 12.1 million people by the year 2030. So there's several different types of atrial fibrillation and flutter, and I thought it would be good to point out what the different definitions mean. It typically does progress from the paroxysmal to persistent states, and patients can move in and out of these different areas. But sort of the definitions to start with are paroxysmal is defined as atrial fib that terminates spontaneously or with intervention within 7 days of onset. Typically, when we see this in medical records, the client has it a couple of times a year, maybe 4 times a year, but it's not an ongoing condition for the client. And they usually don't need to have intervention. Persistent atrial fib is atrial fib that does not terminate on its own within 7 days. Often it needs some sort of medication or cardioversion to restore to normal sinus rhythm. And again, it can either progress or go backwards. And cardioversion is literally where they have to go in and shock the heart. So it's a very quick procedure. They put the client out typically for just a few minutes because it's very painful. I've heard it's referred to as like a kick in the chest by a mule because they literally are shocking the heart back into normal. But very quickly, the heart goes back into a normal heart rate and rhythm. Long-standing persistent atrial fib is when you've had, or chronic atrial fib, is atrial fib that's been going on for the client for over 12 months. Permanent atrial fib is a term that's used to identify persistent atrial fib, but the doctor and the patient have decided that they're no longer going to try to keep it under control. So they're not trying to cardiovert the person anymore, or use ablation or some of the other treatments, a pacemaker, different things to get it under control. It's just mild, and they decided to live with it. And then low atrial fib is a more rare condition. It typically occurs in younger patients that don't have structural heart disease or cardiac risk factors. It is considered a benign condition, and these patients are at the lowest risk for thromboembolism from atrial fib. And I do want to mention, we would like this to be an interactive session. So although we will have question and answers at the end, feel free, if there's anything that you want to ask as we go along, to put it into the Q&A on the Zoom screen, and we'll try to get to them as soon as we see them. So this is a picture of a normal heart and a normal heart in atrial fibrillation. As you can see, the EKG rhythm strip is very steady and normal rhythm. And when it's an atrial fib, you'll see it's very erratic. It's not the same. It's very inconsistent. Dr. Lee, would you like to add anything to this slide about what's happening to the electrical impulses?
Yes, I can. And one other thing that atrial fibrillation is called, the rhythm itself is called irregularly irregular, meaning there is no rhyme or reason to how the beats will come. Some will be slow, as you see on the bottom right. There is a longer distance between some of the beats than there is between some of the other beats. And that's why they call it irregularly irregular, because there's no way of determining how those beats are going to come. At the top, where it has chaotic signals passing through the AV node, those are the areas in the atria, which are the smaller, the upper chambers of the heart, where these irregular impulses are generated. And oftentimes they're generated when those atria, and usually it's the left atrium, becomes enlarged. And in people with chronic heart disease, they're thinking that enlargement of the left atrium is one of the first things that happens in people with chronic heart disease. And when that atrium gets so ballooned out, that's when these little impulses become so irregular, and they can't be passed on to the ventricles in a systematic way. So whenever we see that someone has a dilated left atrium, then that's kind of a hallmark that that person may eventually go into atrial fibrillation. But this diagram is just to show that those are the chambers of the heart where those irregular impulses are generated.
Thank you. And here's just another picture, an enlarged picture, so you can really see how varied, how the distances are. You know, in a normal heart rate, it's just a very steady rhythm. And this is just kind of giving you a diagram. I certainly am asked to look at quite a few EKGs through underwriting, and I've taken some courses. I'm not an expert, but you usually can tell right away when someone is an atrial fib from just how abnormal it looks and its unique pattern.
And on this particular screen, if you look at the bottom where you see all the little wiggly lines at the bottom, right. Well, those little irregular wiggly lines are actually what we call fibrillatory waves. And that's the atrium with sort of a worm-like characteristic, and it's going very fast. And what happens is it's going so fast that only a few of those impulses that are generated go to the ventricle. So whenever you see the beats, the actual beats, that means that it has taken all those little beats between all those little fibrillations to finally create enough power to generate a beat. So that's what all those little squirmy looking lines are at the bottom.
So this slide is just to go over some of the symptoms that a patient might have when they're experiencing atrial fibrillation. palpitations, or like literally feeling that their heart is not beating on a steady basis. They can actually feel the heart rate being abnormal. A sense of fatigue and tiredness, syncope, which is, dizziness and fainting. They get lightheaded. Shortness of breath, particularly during physical efforts, and actual chest pain or discomfort. It is actually painful to them. And many patients don't have any symptoms at all. They find out they're an atrial fib when they go in for a cardiac test, or as I'll speak to later, because they have a home EKG machine or an Apple Watch that tells them they're an atrial fib, but they really don't have any idea that it's happening to them until it's pointed out. I think that's one of the things that's most concerning of all. So the reason that we are so concerned about atrial fib is it is one of the higher causes for strokes. At least 20 to 30% of all strokes are due to atrial fib. Just all-cause mortality due to sudden death, heart failure, and strokes. Left ventricular dysfunction is noted in 20 to 40% of all atrial fibrillation patients. And there's also a related cognitive decline and vascular dementia, even in patients who are taking anticoagulants. And putting a client on on Eliquis or a blood thinner is one of the first treatment patterns that a doctor will do. And this cognitive decline, they do notice that there's more bright brain white matter lesions in patients with atrial fibrillation. So why?
Excuse me, there's one question of what is retrosternal chest pain when you say there may be chest pain. Retrosternal just means behind the breastbone, that there's a sensation of fullness whenever a person is in atrial fibrillation. Sometimes that gives them just a heavy sensation right under the breastbone, right behind the sternum, and that's called retrosternal pain. And sometimes it's not really a pain, it's just a heavy feeling or a discomfort that's not actually a pain that's associated with atrial fib.
Dr. Lee, would you like to go ahead and talk about the anatomy of why atrial fib increases the stroke risk?
All right. What happens, and we'll see in this demonstration on the side that says blood clot, what happens is that when that atria is fibrillating, meaning it's just moving like a bag of worms and it's not actually contracting down like the ventricle to push the blood out of the heart, since doesn't have full contractions and it's just sitting there squirming, the blood doesn't have chance the velocity of the blood is a lot lower. So the blood can kind of stagnate, so to speak. And even though the blood is flowing out of that chamber, there's a lot of the blood that just gets kind of caught along the walls, and especially in that left atrial appendage, that's notorious for allowing the blood to clot in that area. So when the blood clots in that area, and then finally the atrium is able to contract strongly enough to send that blood out, it might send part of that clot out. So that clot gets dislodged whenever the atrium can force it out. That goes into the peripheral circulation, and that's how it goes to the brain from there. And that's what causes the stroke. So the main thing that we don't want to happen is that when someone is in atrial fibrillation, that they develop blood clots in that atrium that's starting to become enlarged and not able to contract down efficiently enough.
Thank you. So this slide is really just to talk about, what causes the atrial fib in the beginning. And I just kind of want to talk through, these contributing factors. It's very common in high blood pressure, coronary disease, and this includes structural heart disease as well as cardiovascular coronary disease, left ventricular hypertrophy, which we often see when someone's blood pressure has not been well controlled, obesity. I just recently listened to a talk on atrial fib that the AIM, the insurance medicine organization, talked about. And he said that he could almost predict someone when their waist circumference was greater than 42 inches, that they were going to be at higher risk for atrial fibrillation. And you know, that was a big clue to him. Alcohol is linked to atrial fibrillation. Caffeine and really all stimulants such as tobacco has seen an increased link with atrial fibrillation. And hyperthyroidism, altitude, magnesium deficiencies, age. It is most common at age 60, but then the age brackets go up dramatically from there. So you're much more likely at age 70 than at age 60. So increasing age. And some other things that I didn't add to this slide, but when someone is particularly tired, has not been resting well, I saw some research that said it's more common if you're from European ancestry, and viral infections. Although I would think that viral infections may be because of their effect on the heart and the chambers themselves. Dr. Lee, is there anything else you would add as to, you know, how these contributing factors make it worse?
No, the only thing that was the newest thing is the obesity, that in years before we never really associated obesity with any particular cardiac arrhythmias, but now it's sort of in the cardiac news now that's definitely a risk factor for atrial fib.
So what do you do if you've been diagnosed with atrial fib, or what do they do to try to control it? So certainly modifying all those risk factors that we just listed, your blood pressure, weight, decreasing your alcohol, caffeine, and of course, avoiding tobacco is always good. So you would like to control all those things and try to keep yourself out of atrial fib. They do have medications that can control your rhythm, and of course, blood thinners and anticoagulants. Eliquis is probably one of the first things a doctor will do when you're diagnosed with atrial fib, and maybe you don't stay on that if it was a, you know, paroxysmal, just a one-time thing, or maybe they keep you on it to see, you know, how often this is going to occur. But that's certainly one of the first treatments. And then the next two are surgical options. And I'll let Dr. Lee speak to ablation and what that procedure entails. I know that we see clients that have ablation 2 or 3 times before it works, and then it seems to work great, and they don't go back into atrial fib. But could you talk a little bit as to how that procedure works?
Sure, I'll do that. And first, though, I'll address one question that popped up, and it asked what the role of stress is if it's a contributing factor for atrial fib. Well, stress itself does not cause atrial fibrillation, but if a person is prone to having atrial fib, stress can certainly be one of the triggering things that touches it off. Just as, for example, alcohol doesn't really cause atrial fibrillation, but if a person is prone to having it, alcohol is certainly a stimulant, just as caffeine, as to touching off episodes. So stress, even though it doesn't cause heart disease, can definitely be a trigger factor for people who already are prone to having atrial fibrillation itself. Now, for the surgical, by the way, before I get to the surgical ablation, see the line on blood thinners and anticoagulants, it used to be that people were put on Coumadin, the good old rat poison or warfarin, But now we have more sophisticated ways of keeping people anticoagulated that don't cause the dread side effect of excess bleeding as Coumadin did. So in the past, we didn't have much else except Coumadin, and it was hard to keep these people regulated because you had to do frequent blood checks to see what their levels were. But now with things such as Eliquis, we don't have to do frequent blood checks. So we have much safer ways of anticoagulating people now than we did in the past. Surgical ablation is usually it's called, and you may see it having been called radiofrequency ablation. And that's just really sound waves that a catheter is put in the area where on the slide where you saw the circular motion in the two atria, the two upper chambers of the heart. Well, that's the area that gets ablated because they do what's called an electrophysiological test. They put an electrode in and they can tell exactly where all of those fibrillatory waves are coming from. And what they do is just take the radio frequency waves and ablate those areas. They just sort of burn those areas out so that all those multiple waves don't occur in that area. So that's the surgical ablation. Many people, if they're lucky enough, have total control with just one ablative procedure. There are some that require 2 or 3 ablations, but usually after the 3rd ablation, they know that that's not going to work. And those may be the ones that are chronically in atrial fib, and they know they're going to be chronically in atrial fib, and they have to be on lifelong anticoagulation, or should be.
Thank you. Yeah, and it seems that they must be perfecting it or getting a lot better, because I see a lot more cases now where we only see it having been done once, and in the past it seemed like it was a lot more. But thank you, I completely agree. And I actually have a slide on this implant, but before we go to that section, a lot of people now that have cardiac disease or have experienced atrial fib get these home EKG machines. They're very small, like not much bigger than your thumb. You can just 2 fingers on it and get an at-home reading. They have them on your Apple Watch, on your iPhone. There's EKG deals. And of course, the Apple Watch now can alert you. The newest version can alert you if you're in atrial fib. It sends a notification to you. So I think for some of these patients that are not feeling symptoms, they are getting alerted to their atrial fibrillation by their watch. And then there are also implantable monitoring devices. Of course, a pacemaker might be implanted for other reasons. And then there's some patches that they can put on the outside of the skin, just I think it more temporary if they're trying to monitor someone. But on this next slide, I'll go into this Watchman implant. I've only seen a few sets of medical records where this particular procedure's been done. But again, this area is where the pooling of the blood is most concerning for the blood clot, I think just because of the way structurally it is. And so they literally put this plug in to block it. And Dr. Lee, I'll let you speak to it more as from your cardiology background.
Okay, well, that's called the left atrial appendage, and it's just like a little ear. And oftentimes it's not as cone-shaped as this picture shows. Oftentimes it's just like a little pouch, a little ear-shaped pouch that's part of the atrium, and that's where the blood can pool most. When an atrium is fibrillating, it can pool actually anywhere in there, but especially in this appendage. And you can see how, since it's so small, blood can get down in there. And if there's not a strong contraction of that little part of the atrium, that appendage, then blood can form a clot. So that Watchman procedure is relatively new, but it's been very effective in stopping clots from going out. And that's what causes a lot of strokes. So far they're finding it to be effective, and I have seen it in, quite a few atrial fibrillation cases. So I think it's being done more and more frequently now that they know it does have good results.
Oh, that's great. I know we refer to our reinsurance manuals for guidance on cardiac disease and medical impairments. And this one just says refer to medical director, which, I guess the reinsurance, they just don't have enough information yet to predict it for us. But it's interesting because usually when we see refer to medical director, we think it's a decline, except maybe in the best case scenarios. But that's good news to know that it's effective and working well.
And I think in the manual, it might be an RMD because it is relatively new still. So each of these cases is going to have to be taken on an individual basis as far as why was that Watchman needed? Was it that the person already had a stroke and now they're trying to prevent another one? Or during the cath or during the evaluation procedure, they noted that there was already a thrombus and they're trying to keep it from going off, even the first time. So for a while, I think whenever you see a Watchman implant, those cases are going to have to be just an individual basis. And that's why they'll probably be RMD until they revise the manual a couple of more times.
Great, thank you. I know we've seen a lot of revisions in this area, but I think it's also because it is becoming such a more prevalent condition. We do have an atrial fibrillation questionnaire. So if you come across a client with this condition, our questionnaire asks a lot of questions about what type of symptoms they're having, what other disease, how much cardiac workup they've had, how long they've had it, and things like that. So, be sure to look for that under our questionnaires. So we're going to go into some case studies. Let's see, it looks like maybe we have a few more questions out here. Okay. The first question I see right now is, can you also comment on supraventricular arrhythmia and how that differs from atrial fib? Dr. Lee, do you want to talk to that? I know that's also a common one we see, but it's really a separate condition.
Right. The main difference between the two is atrial fibrillation is totally irregular. Supraventricular tachycardia is totally regular, very regular. And the thing about SVT is that it comes on suddenly and it ends suddenly. A person might be sitting down and all of a sudden they feel that their heart is beating very, very fast. Then all of a sudden, just as suddenly, it'll stop. And that's characteristic of SVT, whereas in atrial fib, everything is irregular. You might not notice that it's coming on or that it's stopping, but it's characteristically an unpredictable type beginning and an end, whereas SVT is very predictable. SVT can be treated also with ablation. It's a different type of ablation, but the thing that they both have in common is that they both can be treated with ablation. I'd rather have either one. I guess I can't. Yeah, I guess I can say SVT is generally a more benign arrhythmia than atrial fibrillation is. SVT can occur in a very young person, whereas atrial fib is usually reserved for the older age group. SVT can be controlled with medication. Some people can control it on their own by just massaging their carotids or doing a Valsalva maneuver, but people cannot control their atrial fib like that. So SVT is generally a nicer type arrhythmia if anyone has to be a nicer type than the other.
I would agree. I would think of it as being more benign. A couple of other questions I see that have come in. Is atrial fib more common in men than women? I would say yes. Does the insurance blood test, NT-proBNP, give a clue to the control of atrial fib? Dr. Lee, do you want to speak to that one? Because I kind of in my head am thinking, since it's measuring the heart. What would you say on that?
Well, the NT-proBNP is actually a marker for anything that puts abnormal stress on the heart, because the proBNP is stored in the heart cells. And whenever they're stretched, that's what makes this protein actually come out and show up as your proBNP that we see in the blood test. So therefore, it's a non-specific marker, even though it's a cardiac. It's specific in that it's cardiac, but it's non-specific in that it does not tell us what cardiac category has caused it. So atrial fibrillation can certainly be one thing that causes it, because it puts a stress on the atrium itself, because they're beating so fast that they're just kind of a worm-like activity. And it puts a stress on the ventricles, because we have what's called the atrial kick. Whenever the electrical impulse goes from the atrium to the ventricle, then it goes with what we call an atrial kick. So the ventricle can push the blood out, but without that atrial kick, it doesn't push it out as effectively. So in atrial fibrillation, we've lost that atrial kick. So therefore, the ejection fraction isn't going to be as good as we'd like. And there's an overall more stress on the heart from atrial fib. So proBNP can certainly be associated with atrial fib, even though that's only one of many things that can cause it to be elevated.
And I'm going to read one more question, and then I think some of the case studies might help with some of the questions that I'm seeing, or actually two more, because I think I tried to incorporate some of the factors that you want to look at and the effect. But one of the questions was, would the skipping heartbeats or galloping heartbeat feeling people get when lying down be classified as atrial fib? And I would say no, that could be, there's lots of arrhythmias. So I would say that's not indicative just of atrial fib. It could be other things, including the SVT that we just talked about. So do you agree, Dr. Lee, that would be, that it could be more than one thing?
Yeah, a lot of times the ventricular arrhythmias are the one that a person feels when they're lying down. For example, a PVC, a premature ventricular contraction, has the same force as a normal heartbeat. So that's why when a person lies down and they have lots of these premature ventricular contractions, they feel those definitely. Whereas in atrial fib, you can't always feel it as a harsh or a very strong contraction. So oftentimes when people complain of feeling arrhythmias only when they lie down, or they feel them more when they lie down, oftentimes those are ventricular and not atrial arrhythmias. But any of them, I guess, when you're quiet and there's no music, no loud sounds, it just seems to be more pronounced when they're lying down.
And the other question I was going to read before we go into the case studies is, can atrial fib be passed down to biological children if one parent has the condition?
Well, that depends on why that parent has the condition. If that parent has the condition because that parent has been a lifelong smoker and they develop atrial fibrillation because of just many years of all that taxing on the heart, then that's not passed down. There are rare instances of atrial fib where they'll be found in generation after generation, but generally speaking, it's not considered a genetic type arrhythmia. So it's not that if your parent has it, you have a higher chance of having it, because it just depends on what caused it in the parent.
All right, great. Well, let's go to the case studies, and then we'll come back to the questions, because I know one of them is, what's the effect on underwriting? And I could say it's from standard to postpone right now. So this case one example, the client's a 60-year-old male, normal height and weight, and takes a statin and a pill for his high blood pressure. So pretty typical 60-year-old client that we have. So during a recent ski trip, the client goes to the ER, noting he's short of breath and having palpitations. His heart rate when admitted is 150 beats per minute. It's noted that the client drinks several cups of coffee each morning and has been overindulging while he's on the ski trip in the evenings. Atrial fib is noted on the EKG. The client's rhythm converts back to normal that afternoon without treatment. So how would you underwrite? So I know that we're not open for discussion. I wish we were, so we could take a poll or take some comments. But one thing that they pay a lot of attention to, and we haven't talked to yet, is what's called the CHAD score. And this is a score that's given for risk factors for a stroke. So it looks at age, sex, if you have any congestive heart failure history, hypertension, if you've had any kind of a thromboembolic event in the past, like a TIA or an embolism, your overall vascular history, and your diabetes history. And you kind of add that all up and, determine a score. And if the score is low, you're much less concerned that the client's at risk for stroke and needs treatment. But in general, this particular client, I went back to the case. Sorry, I didn't mean to scroll. I think this particular client, as long as they, had a complete cardiac workup and everything was normal, that this may be an isolated incident and could be considered a standard risk. Probably would need a cardiac workup before making an underwriting decision. So that would be to see, because it's so recent, and to see. But this is a pretty typical pattern that I see where somebody, like it's kind of the perfect storm of altitude, probably being tired. This is obviously an active person if they're skiing, I would think, but somebody that might experience atrial fib on a one-off basis. Dr. Lee, any comments you'd like to make on this one?
Yes, well, depending on what, for example, if this man's cardiac evaluation is totally normal, if he has a normal echocardiogram, if he has a normal, say, perfusion study that showed that his coronary arteries are normal, then even though he's 60 years old, he's not in the age category, but lone atrial fib can present like this, because a lot of younger people, and usually lone atrial fib is more common in young men, they overindulge. They might have been on a ski trip. I mean, it's just something that triggers it in them, even though they have a normal heart. So this man may, if he were to have a normal echo, a normal coronary artery study, he might have been considered, even at his age, lone atrial fib.
Interesting. All right, I'm going to go on to the next one. So this client is a 70-year-old male, has had the diagnosis of atrial fib for 3 years. He's on a medication to control it, as well as Eliquis to prevent stroke. He's had a radio frequency ablation in the last year, but has had an episode since the procedure was done. It's noted to have a left atrial enlargement of 4.5 centimeters. EKG is normal on exam. Minimal coronary artery disease is noted in his medical records from a heart CT. He's had sleep apnea for 20 years, but is very compliant with his CPAP. Adult onset diabetes on metformin, but well controlled. His HA1C is 6.7, but his MCV and MCH are minimally elevated. Cholesterol 180, HDL 70. So again, I wish we had the ability to be interactive and talk about the positives and the negatives. And my thought, this atrial enlargement of 4.5 centimeters, that's kind of the beginning of when we would start rating the client. He has had the ablation, and you certainly would consider this chronic atrial fib because he's had it for 3 years. He's got quite a few of the risk factors between the diabetes, sleep apnea, which also increases your risk of stroke, and MCV and MCH are often elevated when there's a little bit excessive alcohol, as well as a high HDL. So most likely he is overindulging, which is contributing to his atrial fibrillation. So I would expect that this client would probably have a moderate rating. Again, Dr. Lee, would you like to add any thoughts or comments on this one?
Yeah, I'd like to put in a what if he were not compliant with CPAP, that puts him at a much higher risk category for his atrial fib episodes. Because what happens is if someone actually needs CPAP and they're not compliant with it, sometimes their overnight oxygen level goes down low enough that that's what might trigger it. So we often like to see, especially with someone with a chronic arrhythmia or a paroxysmal arrhythmia, that they're compliant with CPAP, because if they're not, then in our underwriting minds, that puts them in a much higher risk category.
Absolutely. That's why I added that one to this case study, because I know that certainly concerns me as an underwriter when I see the combination. All right. And the case example 3, client is a 67-year-old male, vegan, normal height and weight, taking Eliquis, blood pressure medication, and statin. After a hike in the mountains, Apple Watch noted he was in atrial fibrillation, went to the emergency room after several days, probably a week, needed cardioversion to convert to normal rhythm. Echo showed atrial enlargement of 4.7 centimeters. And this is where I thought I had corrected this, and a mild enlargement of his heart. Client is short of breath on walks and borderline diabetes. How would you underwrite? So, you know, I have a lot of concerns about this case, noting the atrial enlargement is getting on the more dangerous side. The shortness of breath on walks, you know, needed cardioversion to be treated. This case actually turned out that the atrial fibrillation was a symptom of a much larger cardiac condition. There was endocarditis from an infection that led to congestive heart failure and other symptoms. And the client did end up needing heart surgery and correction of the heart itself. So you know, your heart your heart rate and rhythm is a great indicator of your overall heart health. And again, it can be a sign of things. So, you know, although we are seeing atrial fib on a lot of our cases that we underwrite, there definitely are much worse versions and more mild versions. And so, you know, even though this client, you know, seemed to have a lot of normal risk factors, the atrial fib was still an indicator of something much more serious going on. Dr. Lee, do you want to comment on it?
So in this case, I'm assuming you're saying you would not consider him unless or until he had further cardiac evaluation.
Right.
Yep.
And again, it's a little hard on these case studies because, you know, we're sort of taking just a snapshot of time, but with the shortness of breath and the atrial enlargement, you know, maybe would be highly rated, but I think most likely would be a decline or postpone. In this particular case, everything had already happened. So we kind of knew where it was. Yeah.
This is almost exactly the scenario that was called to me last night by a family friend. You know, I'm very popular when somebody has something going on, and instead of being a hiker, he is a biker, does a lot of bicycling, and said, I just want to tell you that my Apple Watch showed me suddenly I was in atrial fibrillation. So now he sent me all his medical records, and I just looked at his EKG before we came online here, and he has a bifascicular block, meaning left anterior hemiblock and a complete right bundle branch block. I haven't looked any further to see what else is going on with him, but I told him I'm not his doctor, but I'd be glad to look at the records. But this is almost that same type scenario. I do know he's diabetic. I didn't look at the echo yet to see what that showed, but he's still in the process of being evaluated. So these are the ones we need to be very careful of, especially, and this one says borderline diabetes, but anytime they have any other impairment, in addition to the cardiac and to the addition to the atrial fib, we really have to look at them a lot more closely.
Thank you. So kind of just, and I'm going to go back to the questions, but just kind of to sum up what you need to know and what's important to know about your client's atrial fibrillation is how long have they had it? What type do they have? Are there underlying conditions? How is it being treated and controlled? How old is your client? And the frequency of the attack, which of course kind of ties into the type that they have. All right, so I'm going to go back to some of the questions that are still out there. Is high cholesterol or calcium a factor of atrial fib? And I guess I would just say, you know, that both of those things lead to coronary vascular disease, and certainly that's going to be a risk factor. It's causing your heart to work harder. But they're not particularly things that we look at when we're looking at, you know, who's at high risk for atrial fib. Dr. Lee, did you want to add any comment on that?
Yeah, any type of electrolyte imbalance, whether it be calcium, magnesium, or whatever, can affect the electrical conduction of the heart. So whenever a person, whether it be calcium, and that can be a trigger for atrial fib. Some people with parathyroid diseases have atrial fib. So calcium can affect it, but keep in mind that any of the elements, any of the trace elements can affect the conducting system.
If any of you heard our talk last year on women and heart disease, Dr. Lee was big on prescribing magnesium or not prescribing, recommending for magnesium for to help with heart health. So the next question we have is, after an ablation, when should you see your doctor if you're continuing to experience atrial fibrillation?
Well, it's thought that if you have an ablation and you continue to experience, you should be seen right away, because sometimes they found that when they do ablations close together, they're a bit more effective than if you have an ablation and then wait another 6 months and have another ablation. So I'd say if anybody has atrial fibrillation, they've had an ablation, everything seems fine for a week, but boom, all of a sudden they have another episode, then it's time then to go back to the doctor, because if an ablation is going to work, it usually works right away. So if a person has another episode, in a week, it's not good for them to just wait and say, well, maybe the ablation is still taking effect, so I can wait longer. So I think if they have another event shortly after an ablation, that means the ablation just was not successful.
Thank you. And then one of the questions is, what is the entry point and scope of opening for an ablation procedure?
They usually go through the groin. It's sort of like, excuse me, doing a heart cath or doing a stent. They hardly ever have to do any type of open chest procedures for arrhythmias anymore. Most of those are done just with an electrode that's inserted through the groin and threaded up into the heart.
And one of the questions is, what is the effect on underwriting? I think we kind of covered that in the case studies, that it could be standard. I see preferred cases with atrial fib, particularly if it's a permanent case, it's a mild, form, just occasionally, and they are, have good risk factors as opposed to the things that we pointed out that contribute. But certainly, they can have moderate ratings, they can have low substandard ratings. Favorable things that you would look for to give credits to are, treatment with the blood thinner, a favorable echo, stability over some period of time, a few years. So maybe you had atrial fib, but you had an ablation or cardioversion, and everything is fine now. Those types of things. And, so I would say anywhere from preferred to decline, depending on where they are on the workup scale. But typically it's standard to moderate rating, depending on the severity. And we're always open for future topics, but one of them is, do we have a presentation like this on TIAs and strokes? So I don't have anything prepared yet, but Dr. Lee, maybe you have.
I'd have to dust it off. There was one question in messages. Did you see in chat?
I thought I went through everything in the chat.
It said what to do at the beginning of an episode.
Okay, let me go back to. I don't see it anymore. Do you remember what it was that you could speak to?
Yeah, it just said what to do at the beginning of an episode. And if someone has already been diagnosed with atrial fib and you know you have atrial fib and you can feel when an episode starts, sometimes people are just told to take an extra dose of whatever their medication is for the arrhythmia control. Some people just want to live with it, thinking that it'll shortly die down, so they don't do anything at the beginning of each episode. They just watch and see whether that episode goes away on its own, and if it doesn't, then of course they have to see their physician. But there's nothing special to do except in the instances where people have been told to take an extra dose of their medication at the beginning of an episode.
Great. Well, I think we've covered all the questions. If you think of something later on, feel free to email me and I will reply. This recording will be available later, and I'm going to turn it back over to Amber. I did want to mention that just this week, we did come out with a new best practice underwriting guide with all kinds of helpful tips as far as how to write cover letters, how to prepare for exams, how to handle, reinsurance, and just all sorts of good information, vendors, and all kinds of tips. So it was in our Insights email newsletter that went out last Friday. We can certainly send you a copy, but I would really encourage you to take a look at it and review it and use it for training new staff people or, any questions that you may have as well.
There's one more Q&A that popped in.
Okay.
Q&A, one more Q.
Yeah. Sorry, going back to that one. All right. Okay, so this question is the client, the person has a calcium score on an EBCT of 900 plus range. I don't hear much about that score. Is it a reliable risk factor? Yes. The EBCT is a picture of your heart. So, without doing a heart catheterization of the plaque that's on the walls, and the higher the number, it does increase as you age. But 900 is a high number at certain ages. So, we'd have to look at the, we can talk offline about this one, but, certainly the combination of having coronary plaque and atrial fib is something, you should be concerned. All right. Well, Amber, that concludes our portion.
Great. Well, thank you, Cindy and Dr. Lee, for sharing your valuable time and expertise with us today. To reiterate, we recorded this presentation and the recording will be available in Academy within 2 business days. At this time, I'd like to take a moment to ask you to take a short survey today. The survey will populate in a new window when you exit out of Zoom. Please take a brief moment to complete the survey, as it lets us know what topics are important to our listeners and helps make our education program as current and relevant as possible. That concludes our webinar for today. Thank you everyone for joining us, and have a great day.